Good afternoon, everybody. I'll be briefly presenting the airway management in neurosurgery. The main objectives of my talk will be to summarize the effect of the airway management on the intracranial dynamics, the difficult airway scenarios that we encounter in neurosurgical practice, and how to deal with these difficult airway management scenarios, and the potential post-operative airway-related risks that we encounter once we deal with the neurosurgical population. The neurosurgical procedures, they have a unique challenge in that once we deal with these patients and once we are managing their airway, at the same time, once our primary motive is to prevent hypoxia and ensure adequate ventilation and optimal laryngoscopy, this has to come at a cost of not compromising the CNS hemodynamics. The cerebral blood flow has to be managed. The cerebral blood volume has to be kept appropriate, near optimal, and there should be minimal interference with the CSF dynamics. So in other words, there has to be no increase in the intracranial pressure, and we have to maintain the cerebral and the spinal perfusion. As we know that laryngoscopy and intubation are accompanied by a sympathetic response, and there may be an acute increase in intracranial pressure and mean arterial pressure, but this should not be allowed to rise to such extents that a neurological injury may occur. In neurosurgical patients, once we manage them, in addition to having a routine history, physical examination, and appropriate predilection of the various historical parameters that may affect the difficult airway management, we have to keep in mind one particular thing, that once we manage these patients, the neck position has to be optimal. It has been seen that sustained neck hyperextension has been responsible for perioperative strokes. It was seen by Ventrov et al. That they encountered around 160 cases of perioperative strokes in the form of transient ischemic attacks or full-blown strokes. This is one of the common acronyms that can be remembered once we have a preoperative assessment of a neurosurgical population. We have to have an idea about the hyomental distance, the opening of the mouth opening, the visibility of the uvula, the dentition of the patient, the head movements, and the topography of the upper torso. Unfortunately, many of the patients in neurosurgery, they are debilitated, and we cannot do an adequate Mallampati classification in the sitting position. So what we did in one of our studies was that we tried to see that if we assess these patients, we do their Mallampati classification in the supine position, is it a reliable marker of difficult intubation? So what we found that the Mallampati testing, the Mallampati test performed in supine position, it has a higher positive predictive value, and it's associated with more true positives once we compare it with the sitting position. Another thing that we need to keep in mind is the stability and the range of movements of the cervical spine. This was one of the difficult airway scenarios I encountered in my clinical practice. A patient of posterior fossa tumor, and the tumor had invaginated the cervical spine also, so there was severe limitation of the cervical spine, and we had to resort to fiber optic intubation as the conventional means of intubation failed in this patient. This is one of the patients that I have encountered recently, just on Thursday this week. I got a call from our digital subtraction angiography lab, and this was one of the patients who was scheduled for coiling of the ACOM aneurysm, and the attending anesthesiologist, he called me that the patient is having persistent hypertension post intubation. And once I requested for a scan there in the DSA lab only, we found that the patient had a rebleed post intubation, probably as an exaggeration of the sympathetic response. The anterior interhemispheric fissure showed fresh bleed, and there was an intraventricular hemorrhage. So to obviate these catastrophes, we have to have a fair idea of the intracranial compliance once we deal with these patients. So we have to keep a close eye on patients that have a midline shift, a significant midline shift, obliteration of the basilar cisterns, or there is profound hydrocephalus. These patients are a group of patients which may decompensate anytime. And once we deal with these patients, we have to blunt the tracheal responses, sympathetic responses, by additional doses of opioids or thiopentone, propofol, or beta blockers, or intravenous lidocaine that's commonly used. These are some of the caveats that all of us have been taught during undergraduate and postgraduate days, that once we deal with patients having a narrow cerebral compliance, we have to avoid hypertension, hypoxia, hypercapnia, avoid compression of the jugular veins, and avoid using cerebral vasodilators once we go for anesthesia and induction in such patients. It has been also seen by Bosman et al. That if we go for rapid sequence intubation, it may result in a profound increase of intracranial pressure that may be threefold than the baseline. So we have to judiciously go for rapid sequence regimens and keep a close eye on the cerebral compliance while managing these patients. Traumatic brain injury is one of the common airway scenarios that we encounter in our clinical practice. And if we give hypoxia, hypercarbia, hypotension during induction, it may result in a secondary brain damage that may alter the ultimate outcome of the patient in terms of the Glasgow outcome scale. At the same time, once we deal with these patients, we have to keep in mind the basilar skull fractures. There have been case reports where it has been seen that the endotracheal tube has got migrated into the anterior cranial fossa. At the same time, a Foley's catheter inserted for control of epistaxis, again, it has got migrated into anterior cranial fossa. And similarly, a nasogastric tube. So we have to be very cautious while dealing with these patients who are having basilar skull fractures. Another important group of patients that we encounter in clinical practice is the acute traumatic cervical spine injury. And it has been seen that around 13 to 30% of patients, polytrauma patients, they do have spine injuries. And it has been seen that if the GCS is less than 8, the incidence of cervical spine injuries is around 10%. So if we miss this cervical spine injury while intubating a patient, the patient may develop a permanent neurological deficit. So we have to keep our eyes open, diagnose the cervical spine injury in terms of clinical evaluation and radiography. The clinical criteria that we use if we have a patient who is conscious, having a GCS of 15, there is absence of drugs or intoxicants, there's no midline pain or tenderness, full range of active movements, or a no neurological deficit. So we may safely rule out cervical injury in such patients. And again, if we use the radiographic views, we use the normal AP view, the lateral view, where we see the integrity of the Dennis 3 columns concept we use while interpreting a lateral X-ray of the neck. And then also at the same time, we have to evaluate the cervical spine on the odontoid cervical spine X-ray films. A CT scan is very valuable marker of acute spinal cord injury and acute spinal cord contusions and may help to change the patient management. And if we have a patient who is with unstable cervical spine, we need to go for an awake flexible bronchoscopy for intubation. We can go for a direct laryngoscopy with inline uh, stabilization. There has been a series of cases that have been published from South Africa where they have used retrograde intubation that can be used in a resource constrained setting if the caregiver is very well versed with this technique. The commonly used immobilization techniques while dealing with these patients are the manual inline immobilization. We should not apply traction or immobilization of the head between two sandbags. We should remember that rigid cervical collar, once we use it, it's associated with increased difficult intubation and the risk of aspiration may be increased. And it does not really protect against the movement of the occipitocervical and cervical thoracic junction. It has been seen that the use of video laryngoscopes at the airway scopes, it results in a better laryngoscopic visualization, reduced intubation difficulty scale, and it has been seen that the use of airway scope, the intubation was faster and there was a better laryngeal view. At the same time, the use of airway scope has shown, also the use of laryngoscope has shown reduced cumulative cervical motion of the vertebrae during intubation. So once we summarize the effect, what we need to remember during patients with acute cervical cord injury, we need to remember that once we go for laryngoscopy, there is a superior rotation at occiput at C1 and C3 and C5 have a mild inferior rotation. Also, at the same time, we have to remember that there's a greater movement with chin lift rather than intubation, and cricoid pressure does not really result in any significant movements. It's better to proceed with the technique that the operator is most experienced with. Whatever we are comfortable, let us proceed with that. If a patient operator is not expert, doesn't have an expertise with a flexible bronchoscope, it's better to go with a conventional laryngoscope. Another group of patients that we encounter in neurosurgical patients are the chronic spine disease with myelopathy. These patients may be having ankylosing spondylitis or rheumatoid arthritis. The main problem in these patients is that there's a reduced mobility of the atlanto-occipital and atlanto-axial joints, and we are unable to give a proper sniffing position in these patients. Again, we can have laryngeal involvement in these patients. There's mucosal edema in these patients because of the connective tissue disorder, which may result in significant post-extubation stridor, or there may be limitation of the temporomandibular joint mobility, which may cause limited mouth opening. At the same time, these patients may have atlantoaxial instability that makes their airway management difficult. There may be vertical subluxation or cranial settling of the vertebral column in these patients. Once we deal with these patients, we should remember that once we manage these patients, they should be treated on the similar lines as we treat patients with cervical spinal cord injury. And it's preferable to go for a fiber optic bronchoscope if the operator is comfortable in using it, he has an adequate experience, and to go for a neurological examination after the patient has been intubated. Many a times we get a good number of patients in clinical practice with head fixation devices. And again, they pose a challenge once we have to manage their airway. It's better to go for an awake fiber optic intubation once we need to manage their airway with the head frame in situ. And once we have a head frame or there's a halo fixation in situ, we should remember that the alternate equipment for intubation should be always available. And in case of an emergency, the neurosurgeon has to be very comfortable as how to open the halo. The requisite equipment should be readily available so that in case of an emergency, we are ready to salvage the airway. A study was done by Berger et al. And it was seen they had around 14 patients with halo fixation, and unfortunately, around 7 patients needed immediate airway rescue and developed airway related complications. So rescue techniques in the form of video laryngoscopes or fiber optic bronchoscope has to be easily available once we manage in these patients. Again, functional neurosurgery patients who come for surgeries for the ill-located areas of the brain or deep brain stimulation, they undergo either awake craniotomy or a sleep awake sleep technique. And in these patients, in addition to the laryngeal mask airway, there is an increased use of esophageal nasopharyngeal catheter, where we place this flexible catheter in the esophagus. We inflate the proximal and the distal cuffs in the esophagus. The proximal cuff is there at the root of the tongue. The patient receives air, which gives passive oxygenation to the larynx. Again, we can use cuffed oropharyngeal airway, or we can use a bilateral nasopharyngeal airway, which is connected to a double lumen adapter once the patient is sedated. Patients with acromegaly and Cushing's disease, they again pose difficulties with mask ventilation and airway obstruction, and may have an increased incidence of obstructive sleep apnea, obesity, or vertebral crush fractures. So these patients may present with unpredictable difficult airway or a problematic mask ventilation due to prognathism, microglossia, or thickening of the vocal cords. Awake fiber optic intubation may be helpful in these patients. We did a study where we tried to see the incidence of the predictors of difficult intubation, and it was seen that duration of the disease was one of the predominant predictors of difficult intubation in acromegalic patients. Post-operatively, these patients may develop airway obstruction and may have a propensity for negative pressure pulmonary edema. In pediatric neurosurgery, we frequently encounter congenital hydrocephalus, craniofacial dysmorphic conditions, and craniospinal dysraphism. And these patients may have microcephaly, mandibular hypoplasia, and maxillary hypoplasia. So a scary airway scenario may be seen in a clinical practice. And many of these patients, they may have difficult bag mask ventilation or difficult tracheal intubation due to abnormal upper and lower airway anatomy and physiology. Often there is mid-phase retrusion that brings the soft palate against the posterior pharyngeal wall, and that may result in sleep apnea. If we have an expertise that is available in our centers, it's better if we have a syndromic child and we have a difficult airway. A preoperative endoscopic airway evaluation may be helpful. This was one of the craniophagus that was operated, again, a very difficult airway. One of the first craniopharyngus that was operated in our country, and thankfully both the babies, they were discharged home in a healthy condition. There are some airway related potential risks that we have. We can have obtundation of the airway, which may result from seizures or herniation or ischemia in the post-operative period, or it may be even as a result of the residual anesthetic drugs. Then we can have surgery-related airway injuries or position-related airway problems. It has been seen that after supratentorial craniotomy, we can have a limited mouth opening, which may be consequent to the scarring of the temporalis muscle. After anterior cervical spine injury, we can have low vocal cord paralysis due to compression of the recurrent laryngeal nerve, or there may be upper airway edema, which may develop around second to third post-operative day. We can have even migration of the bone or synthetic graft into the airway, or we can have difficulty in intubation once we have gone for occipital cervical fusion. And once these patients come for reintubation, we can have a difficult airway. Again, in posterior fossa surgery, we can have lower cranial nerve palsy, or the control of the respiration may be jeopardized as the respiratory center is nearby. And at the same time, in patients with posterior fossa, we can have facial edema, microglossia, and oropharyngeal edema due to once these patients are being operated in the sitting position. This is one of the patients that we had in our clinical scenario. Once we used to extubate this patient, he used to develop stridor in our ICU and even in the immediate postoperative period. And what we did, we put an Ommaya reservoir, and we meant for repeated CSF withdrawals, and that is what settled the patient. So we have to keep all these things in mind once we manage the neurosurgical population. Thank you very much.